Let's take a moment to talk about pathways in the patient who has a base of tongue tumor. So, our pathways in the base of tongue tumor, I want you to start to think of this patient at three different stages. The initial stage is going to be diagnosis. The second stage that your patient is going to go through is, of course, their treatment. And the third stage that your patient will go through is going to be what we consider rehabilitation or the recovery stage. And so this patient is going to go through three very different types of side effects, modalities, and complications that you would never believe. So, as a therapist, first pause and go, okay, my patient has a base of tongue tumor. Base of tongue means, for short, BOT. Here's going to be our patient, this tumor. There's our neck. We've got our lateral view. This particular patient's tongue is going to start at the tip and hover back. Somewhere along the line, that patient has a not fun guy hanging out. The base of tongue tumor is going to impact their ability to do many different things. So first, let's start with our patient at the time of diagnosis. We've created a model to be able to help you navigate your patient, navigate and educate your patient on the expected side effects and timeline. So let's go through here at diagnosis. And let's take a moment to think about what are their symptoms when they walk in the door. Oftentimes these patients, for example, I saw a patient today and they said to me, why am I even here? My doctor sent me, I'm trying to follow their directions. And I said, listen, I get it. This whole speech therapy gig and our name just doesn't match what we do. So you are here because you have a spot and he's misbehaving. And I blame everything on the spot. So I say there's an area in the back of your mouth. That particular area is going to be treated. And I educate them and talk to them and say, tell me, what do you know so far about your diagnosis and your plan? Well, I know I have a tumor in the back of my tongue. Some patients can't even tell me that. They just say, I have cancer somewhere in here. And I say, okay, during your diagnostic workup of you visiting with me, we're going to evaluate what is going on with your swallowing. Now, as a therapist, there are two ways you can evaluate this. The ideal gold standard of care, in my opinion, I'm going to say my opinion, is going to be a FEES. Why would I like a FEES visit one? Well, I know my patient is going to go through over here treatment, and then during recovery, they're going to experience external and internal edema if they are being treated with chemo RT for their survivorship goals. So I know that if I can compare a FEES at the time of diagnosis combined with a FEES right here at the time of 4 weeks post rehabilitation, I'm going to be a happier speech therapist because I'm going to have objective data to be able to tell me how did my patient look at the start of treatment from a swallowing standpoint, what changed, and how does my patient look right now today in my clinic after their treatment. So ideally we get a FEES. Now, for the patient who says, listen, lady, you're not sticking that camera in my nose. I'm sick of people sticking cameras in my nose. I actually do honor that. I honor it. Why? Because we believe this is the gold standard to have objective data. We want a modified or a FEES. One is necessarily not better than the other, but I love the FEES because later I'm going to use in our model a revised Patterson scale to look at internal edema. So if I go ahead and the patient says to me, no more cameras, I'm tired of them. The doctor just did that to me 3 days ago. Nothing has changed. Everything's fine. I try my best to educate them as to why. I say, okay, I get it. I understand this is overwhelming. Our goal is to find out how your swallowing is working prior to your treatment, so that will better guide our outcomes after your treatment. We are here today really for the future. We're not here for right this moment. We are here to be able to help your body manage these symptoms and keep a feeding tube out of you as long as we can. That's our goal, and support your swallowing and safety. If I say it like that, usually my patient will shrug their shoulders, change their mind, and say, well, go ahead, Lauren, whatever you have to do. So ideally, on our first visit, we would get a fibroendoscopic swallowing study. That would be ideal, so we get some images. Now, let's go to our next little checklist of our patient. Here's our next checklist. Of course, we are going to do an oral motor exam. So oral motor exam. Next, we are going to go through with our patient, receive consent for photos, because I want to know what is their baseline looking like. So photos. Then we are going to go through, we are going to do neck measurements. Neck measures. Now we're going to do mouth opening measures. Why would I do mouth opening measures on a base of tongue tumor? Well, we know that over here in this particular stage of the model, that patient's going to have issues at their masseter. Now, this patient is going to have a FEES, an objective assessment of their airway compromise, what their muscles are capable of. They're going to have an oral motor exam. They're going to have photos. They're going to have neck measurements. They're going to have mouth MIO measurements. They are also going to go through and receive the education for exercises, because they need to know what are they doing to keep them doing our evidence-based practice of eat plus exercise out of MD Anderson. So we are going to follow that. And then I am going to talk to them about the next stages of their treatment. So we are just in the diagnostic stage. Hopefully you are receiving these patients. Let's talk about a timeline for a second. Hopefully you are receiving these patients either time of diagnosis, ENT, send you a referral, radiation oncology, send you a referral, oncology, send you a referral. So you get to see this patient at the same time they are seeing the dentist and all of their fittings for their masks, and they haven't started treatment. If that's not the case, in a perfect world, you are going to get them over here in this paradigm, and you are going to receive them during treatment, hopefully weeks 1 or 2, because you want to start them on some strategies. All right. So during the first assessment, as a speech pathologist, my goal is first, love my patient, learn them, reassure them, find out where they are in the space of this diagnosis because it's overwhelming, and then meet them where they are. Teach them, why in the world did the doctor send you to a speech therapist? If a doctor has sent you to a speech therapist, you're going to be experiencing the side effects of your treatment combined with the side effects of the cancer itself. And we are going to be able to help you not only right this moment, but really our goal is a year from now, 2 years from now, and 10 years from now to be able to keep showing up at all of your grandchildren's birthday parties, being able to enjoy some of the meals with them, because we know with a diagnosis in head and neck cancer, swallowing will be impacted for the remainder of our life when the treatment modalities are surgical, chemo, or radiation. It comes with the territory. So next, we're going to explore what does sort of our treatment education look like? Because in the diagnostic workup, not only am I navigating here with my patient in this diagnostic workup, what is my role, but I'm ensuring that I am continuing in this particular model. All three of these circles need to meet. What separates my brain from that of the brain when I was stuck working in the corporate world is if I don't pause for a moment and I don't enjoy and honor where my patient is in this aspect of their life right here, and I don't stay as honest with them as possible and say, these circles all meet. Here in the middle is your quality of life. We are always putting that first. What is important to you is going to be important to me as your therapist. So, right here, we are always adding quality of life measurements additionally in this particular series. So, for these patients, we could consider basically doing a combination of, an Eat 10 or an MDaddy, which is an assessment that's going to be able to help us understand which of the consistencies of liquid or food are giving them the most trouble. And so we're going to include these measures and then be able to compare them later down the road. I like to send these to my patients prior to them walking in my door so that I know what's happening to them. We send those messages electronically at the time of scheduling, or our clinic coordinator is able to talk through and ask if it's an Eat 10, for example, those 10 screener questions. That also starts to show our patient that we're invested in you, that we are here to be able to help you through your treatment. Because one of the hardest things in this diagnosis is showing up to all of these daggone appointments that everybody sends you to. So let's continue to explore our next cycles and what that may look like.